I'm Dyfrig Ap Dafydd. I'm a GP in Llangefni. I've been a cluster lead in Anglesey and I'm one of the primary care leads for the Planned Care programme. This is the second video in a series of videos looking at searches and prompts and templates and suggested recall management for our QI projects this year. One of the Planned Care programme's main projects is the Community Health Pathways. This is a series of guidance and pathways to support GPs and primary care clinicians to manage a variety of conditions. I think these are very impressive, very good. There are pathways for conditions that might not have been localised to your area of Wales yet. The goal behind the programme is to agree a pathway nationally, and that's involving national networks working with GPs and senior medical experts to agree a pathway on any given condition in Wales. Those pathways will then be localised by GPs in your area, working with consultants or appropriate specialists in your area to make sure that any local arrangements are clear, so that guidance on how to refer, who to refer, so phone numbers or appropriate letters or appropriate services are all here, all easy to find, all in one place. If there isn't a guideline that's been localised in your area, you'll still be shown a guideline if it's been created in Wales. So for example, the hypertension guideline is the Cardiff and Vale guideline. Now, what this means is often the guidance will be relevant and appropriate, it's going to be up to date, and it's been reviewed by GPs and consultants and specialists in Wales, but possibly not localised to your area yet. This is a work in progress. I still think they're very useful to be aware of, and also most of these are still going to be relevant and appropriate for us to follow. You might find that there is variation in what you request and perhaps how to refer and who you might refer to, although I think for many of these it'll be fairly intuitive and reasonably similar across Wales. So please don't be intimidated if your pathway page says it's not been adapted for your area yet. It'll tell you where it has been adapted, and I think it's still reasonable to follow these or at least be aware of these. I think they're still very, very useful guidelines because we know they're up to date. It's likely to be more relevant to us in Wales than perhaps NICE guidance, although, I guess you might still want to follow NICE guidance, but that what this means is that someone in Wales has looked at all the relevant guidance, has agreed it with a Welsh specialist, and it will come to your area soon to be reviewed and localised too. Now, if you've seen video 1, you'll see that there was a folder for chronic kidney disease, and you'll see there's a headline audit search, which is just showing you the data that's very similar to the Audit Plus data, looking at where you are for your cardiovascular disease prevention. So if we open that up, it'll give me my population number, it'll give me how many are on my hypertension register, how many perhaps should be on my register, how many perhaps we could take off the register, although I'd be tempted to leave them there for ongoing monitoring, how many have got AF, how many have had their blood pressure, lipids, HbA1c, UNEs and ACRs done, how many have had a Q risk and whether they're on a statin, and then also looking at whether people have had their blood pressure in the last 15 months, whether it's to target, whether that's a target but over 15 months. And then you can't see at the bottom of the page, we do have to cut off elements of the page to protect any potentially patient identifiable information being shown. There are the searches looking at how many, search 1 priority group patients with a blood pressure over 180 over 120, and then patient group 2, patient group 3, patient group 4, as per the guidance. Most of our patients fall into patient group 2. The reason for this is actually because they haven't had a blood pressure in the last 15 months. We know since QOF changes that we've lost some of the searches for this, and we've also lost some of the prompts for this, particularly in EMIS. And so there is a need for catch-up. We know that the hypertensive population is an already at higher risk than the rest of the population of cardiovascular disease and cardiovascular events. Patients with hypertension are already at higher risk, and we know that controlling their blood pressure reduces that risk down, 20% as a general rule of thumb. If you can identify someone with a Q risk higher than 10% and you give them a statin, you're going to reduce that cardiovascular risk event by 25%. if they're actually in groups that are eligible for ACEs and flows-ins, we're going to reduce that risk more. This is the low-hanging fruit. This is the population where perhaps we haven't been targeting them as aggressively as we should. We haven't been identifying those with high cardiovascular risk as aggressively as we could. And we haven't been giving that population statins and reducing their risk even further where appropriately. If you can find this population and manage blood pressure, you're reducing cardiovascular events. If you identify those at risk and then give them statins, you are reducing cardiovascular events. If this was your family, your friends, your neighbours, this is significant numbers here, and we can really make a genuine difference, and I think there is a strong value in this project. I particularly like the fact that we're targeting those already at risk. We know that we're going to get a good return for our time and investment here, for our patients, who are often our friends and family, and for the population at large. And again, we've got the breakdown in the searches here. So if I choose the cardiovascular disease prevention searches, we have our headline, who's on our register, who isn't a target. So we've got 350 patients not a target. They're broken into those who are very high and those who have high or high with comorbidity. This is where I've slightly altered the search because I've taken out, at this point, the patients who haven't had a blood pressure in the last 15 months, because these are the patients who we know are high and need to target. I'll come back to that. And then we have our not target groups, but without comorbidity, and those who aren't target and who haven't had a blood pressure in the last 15 months. Quite a lot of these people are actually to target. So out of 1,000 patients, about 2/3 of them are to target, but a significant proportion of them haven't had a blood pressure in the last 15 months. We've run Q-risks on most of this population, and I think I'm a little wary of batch adding Q-risk or showing how to batch add Q-risk, but we've done some of this work just to get an idea of numbers involved here. And so we found of our 1,000 hypertensives that 140 of them have a Q-risk over 10%, 130 have a Q-risk over 20%. Now this group here, if you can manage their blood pressure well, you are reducing, even if we said 20% reduction in cardiovascular risk if we control their blood pressure, 20-25% reduction in risk if we're controlling their cholesterol or putting them on a statin. And at the risk of overemphasizing how important this project is, just back of fag packet maths tells me that if 20% of these are going to have a cardiovascular event in the next 10 years, that's we're looking at about 25 patients there. And if we can reduce a quarter of those, we're going to save 7 people, say, from a cardiovascular event in the next 10 years in this group. If I multiply that for Anglesey, that's about 70. If I say North Wales, that's 700 patients who would not have a cardiovascular event in the next 10 years if we put them on a statin, according to the statistics, and that's conservative here because most of these will have Q-risk percentages much higher than 20. And if we consider the impact of that nationally, and then that's just 10 years, we're talking, if we're looking at people's lifetimes of 10, 20, 30 years, you begin to snowball up into much bigger savings that benefits everyone in primary, secondary care, workload, impact in the future, and I suppose, for the individuals involved as well. Again, we've created further searches so you can look at your coding. So this is looking at who's on my hypertension register, who isn't on my register, and should we be coding them? And you might want to look at ways of adding those to the register as you go. I'll come back to that in a further video we're going to create on templates and prompts. There's a separate folder for the priority groups. So this is priority group 1. I have 14 patients with blood pressure over 180/120. I have 500 in group 2. So this is the group where they're either poorly controlled or there's not been a blood pressure in the past 15 months for this population. I have 70 who are group 3. This is where they are raised blood pressure, but they don't have comorbidity and they're not over 160 or 100. And then 400 whose blood pressure is to target. Now, this one here is has been split slightly again, just to show that of this group, the majority are patients who haven't had a blood pressure in the last 15 months. So this is an area for my practice. We have been catching up on this since COVID. We've been aware of this. It is simply an issue around capacity and trying to get these patients in. But we know that we are getting more and more of these through the practice as we go. And we want to make sure that when they do come in, that they're targeted well. Now, the main goal of this QI is to identify our hypertensive patients who are most at risk of cardiovascular events so that we can modify and optimize the management in those patients. And I can appreciate this is a busy screen, so I may spend a little more time on this search. At the bottom here, if I go straight to search 2, this is looking at those on my hypertensive register who have had things like the ACR in the past 15 months. Have they got AF? Have they had their weight done, their blood pressure done, their HbA1c, their lipids, their Q risks, or their U and Es? Now, I think there is a question for capacity in practices and how well they can manage this. And again, I'll come back to some suggestions around how to break this into more manageable chunks when we have a video on catch-up and month of birth. But this does give you a baseline and an idea of the scale of the work involved. There's 2 searches. One is looking for the past 15 months and one is looking for have they had this wider cardiovascular screen done ever. And you can see that 50% have had ACR, BMI, HbA1c, lipids, and a Q risk done in my practice, which I think is actually probably going to compare reasonably well because we're quite good at Q risking. We use inbuilt Q risk 2 in EMIS, and this is where I want to come back to these searches here. This is looking for have we ever done a Q risk, or is this person on a statin already? And my numbers for this are quite good because we've done quite a lot of Q risking work over the past few years. I think it's important to emphasize here that NICE does say we can use inbuilt Q risk 2. And just to emphasize that point, if we go to the NICE guidance, NG238, cardiovascular disease assessment or reduction prevention, if I go down to section 118, it's very clear that NICE is saying, yes, use Q risk 2. We all know that doing Q risk 3 takes an awful lot of time, and I think it does disincentivize us doing that for this population. What NICE asks us to be mindful of is that if you have someone with a Q risk score, say a Q risk score under 10%, if they have SLE, migraine, severe mental illness, erectile dysfunction, or if they're taking steroids or atypical antipsychotics, Q risk 2 may be underscoring them. Now, we have done a little bit of work looking at how many of our 1,011 patients had a Q risk score under 10% and had any of those conditions, so SLE, migraine, corticosteroids, atypical antipsychotics. And yes, we have 30 patients out of that 1,011 who have some of those issues coded. Just out of interest, we look to see how many of those would then have a Q risk score that went over 10% had we used Q risk 3, and out of those 29, it was 2 of them. So you could Q risk 3 1,011 of your population, or you could Q risk 2 1,011 of your population, and if you're using 10% as your cutoff for treatment, which I guess we are considering here because they are a higher risk population, they're already hypertensive, then it would have changed our management for 2 of them. So 2 more people would have been scored as 10% or higher than might have been otherwise out of 1,011 patients. So I really question anybody really spending an awful lot of time doing QRISC-3s manually for their whole population, particularly when NICE is already saying, yes, continue to use the embedded QRISC-2 in your system. I just think pragmatically we shouldn't be wasting clinical time on manually inputting into QRISC-3, although clearly that would be for practices and their clinicians to decide on that. In any case, we've got searches for those whose QRISC is over 10%, looking to see are they on statins or not. Those whose QRISC is over 20% and looking to see if they're on statins or not. What you can see for mine is that of my population, about 240 of my 1,000 have a QRISC somewhere between 10 and 20%, and about 380 of my 1,000 have a QRISC greater than 20%. Fortunately, quite a lot of these are already on statins, and I think this is the point. We know that these people are at high risk of cardiovascular events, and we know statins will reduce that risk by 20–25%. So I repeat myself, forgive me. The other folder of searches is for the old QOF rule of screening for blood pressure in people over 50 every 5 years. So what's gratifying for me is that I have 2,400 patients over 50 who have had their blood pressure done, but there are still 676 patients over 50 who haven't had their blood pressure done in the past 5 years. I appreciate that we're not going to be able to do all these things all at once, and a lot of QIs around putting in systems in place so that going forward we are inviting people in, we're trying to make sure that when they are there that we're capturing the processes we need, and that when patients are with clinicians that are aware of what they might need to consider doing for those patients in front of them. So that'll be covered in a video where we've got suggested prompts and templates. So in summary, there is the broad headline search that gives you your figures, and that's this audit search here. This one, you can run it at relative run times so that you can run it at different times during the year, so you can see if what you're doing is making a live difference to your data, which is handy for any cycle of change review, any PDSA review. We know that data is available in Audit Plus and in the Primary Care Information Portal, but you can export it into Excel, you can chart it yourself, and some practices may wish to do that. The further searches, I appreciate it may need a bit of time to go through them to understand what your baseline is and give you an idea of where you might want to focus attention or target attentions at the moment. And I will be creating further videos. So there's video, we've already done one for the CKD project. There'll be a video demonstrating why we're also pulling in diabetes, and videos on the templates and the prompts that we've created, and then how to import searches and how to import the templates and prompts, with a couple of videos looking at how you might want to have merged diabetic annual plan and how you might want to code frailty.